Epidemiological Principles of Disease and Pandemic Control and Prevention, part of 11th anniversary celebration at Docplexus. Today, we are honored to have with us an eminent speaker, Dr. Amitav Banerjee, a distinguished name in the field of community medicine. Dr. Banerjee is a professor emeritus in the Department of Community Medicine at Dr. D.Y. Patil Medical College, Pune. Dr. Banerjee's illustrious career spans decades, including an impressive tenure in the Indian Armed Forces from 1978 to 2005. He has made significant contribution to the field of public health through his extensive research with over 100 papers published in national and international journals. Beyond research, he has spearheaded multiple funded projects and captivated audiences with his keynote addresses at prestigious conferences worldwide. As healthcare practitioners, understanding the epidemiological principles of disease control is crucial for safeguarding public health, especially in times of pandemics. Dr. Banerjee's deep expertise and vast experience will provide us with actionable insights to better address the challenges in our practice. Without further ado, let us warmly welcome Dr. Amitav Banerjee to take us through this vital topic. Over to you, Dr. Banerjee.
Thank you, Sitil, and thank you, all the viewers. Good evening to everyone. And it's always a pleasure and an honor to come on the Docplexus platform and share the views. So, today we'll be discussing about the epidemiological principles, and we will be taking the examples from the recent pandemic which got over. And I'll be just going basics. Uh, the basic questions in a pandemic epidemiology of anything or disease outbreaks, particularly, I'll be focusing more on communicable disease, the, keeping the recent pandemic in context. The we should ask the correct questions. The correct questions are person, place, and time. The person means who are getting affected, where they are getting affected, the time sequence of time, how it is spreading, and then what can be done and how to control it. So these are the questions we have to ask, and these questions will have different answers depending on the geography. So, and regarding the principles, like the principles of communicable disease control is like if there is a fresh outbreak, you try to contain it so that it does not spread further early in the pandemic. So it is just like driving a car. I'll be just giving some examples. Journey in a pandemic is like driving a car skillfully, and it is a dynamic process, and one has to adjust continuously. When you drive a car, you when you start in the first gear and you change the gears according to the traffic, according to the situation. And when you put the first gear, it is very fuel intensive. It consumes a lot of fuel, and as the car, as your journey progresses, you have to change gears. Similarly, if a runner, a sprint, you run a sprint at full speed, but when you have to run a marathon, the pandemic started as if we will control it within 100 days or within 2 weeks by full deploying all the resources and heavy resources, and but it continued into a marathon, and we should have changed course in between. So human too cannot sustain speed of a sprint when the race becomes a marathon. At the end of the drive, that is when you are thinking that you are at your journey of the pandemic is over, you can again slow down to first gear, but which is very resource intensive. And that if you are going for a eradication, if it is feasible and if it is worthwhile. So we will just see whether taking the example of COVID, how the journey started. So the first gear is very intensive, and we started with test, trace, treat, and isolate. You see, testing requires a lot of resources, lot of kits, and trace is a very, very cumbersome process. You have to catch each one, trace who all came in contact, and a person comes in contact with so many people, and it's a it's very effective if the outbreak is very early because there are few cases and few contacts. Then you can treat and isolate them. So that is the first gear. But this is effective in early phase of a pandemic. But unfortunately, in this pandemic, we continued in the first gear for a long time. Test, trace, treat, and isolate. And I will just show with figures how little we could achieve from this and how resource intensive it was without getting the returns. As an epidemiologist, I have to substantiate here with the figures. I can just count the numbers and just show whether this is very intuitive that you can, throughout the pandemic, you are testing the person, you are tracing, you are isolating. But how much? Because when we see the whole population, what little impact it is making on the population, we have to see. Or so this is the, as I say, early in the pandemic, this is effective. But once the pandemic progresses and we are unable to check it, which is very likely when there are large number of mild cases, as we had in this COVID-19, large number of mild cases, large number of asymptomatic cases, and by the time we could identify the transmission kept on propagating. So one sprint has turned into a marathon. Community transmission has occurred. We have to conserve the fuel. We have to go on top gears where we may not get the full power, but we will conserve it when the journey is long. Once community transmission is sets in, it is not efficient to continue with resource intensive test, treat, and isolate strategy, particularly in high dense countries like India, Africa, and Asia, where there is very high population density. You cannot chase the virus. They will be spreading faster than you can test. And as we will see from the subsequent figures, we could hardly achieve anything by most intensive testing, which was very resource intensive. It drains the resources and disrupts trade and social interaction, leading to a fractured society. Initial, okay, isolate, quarantine. But once it has gone into community transmission, we have to just see again, we come back to the epidemiological principles. Who are affected? In COVID, early in the pandemic, first 3 months, we knew it was the people with comorbidities and the elderly. The average age of death in Italy and Europe and USA in nursing homes was 80 years. You see, so the younger population was not at risk. So we could have done, instead of draining the resources, instead of closing the schools, instead of doing lockdowns, instead of disrupting trade, we could have used the epidemiological principles as a risk approach. This is called the risk stratification. That elderly could have been protected. Schools could have, the Sweden kept the schools open and there was no excess morbidity mortality in Sweden, neither among the school children, neither among the teachers also. So that we should have a flexible, when you are driving a car, you change the gears according to the road conditions, the traffic, the crowd, and all that. And particularly in India, in a crowd, you can, very high dense populations, overcrowded living conditions, you cannot adapt the measures which are being adapted in the West. In the West also, they were not successful in restricting the virus. The virus came all the way from China to Chandni Chowk. So we should have taken a course correction. These lessons are good for the future pandemics, that we should not again raise the panic button. And most importantly, it does not achieve its objective of breaking the chain of transmission, as subclinical cases far outnumber the overt cases. For every one case, there were 30 cases who were subclinical, who were moving around. So this example from recent pandemic of countries, a vast ocean of people living in crowded conditions. The recommended strategy of test, trace, and isolate hardly made any dent on the spread of infection, identifying all with infections. We could not identify. Only a fraction of infections were identified by these methods to break the chain of transmission. So these are the figures I was saying. We can substantiate this, how effective we were by these figures. The June 2021 Sero survey by ICMR showed that 60% of Indians had antibodies, that I have given the reference. So 68% translates into almost 90 crore Indians. And once you are having 68% antibodies, agreed that some of them may be due to, say, at that point of time, only 5% had got two doses of the vaccine, and only 20% had got one dose of the vaccine. So, okay, we just take away that, and that means more than 75 crore people had got infected by the virus by natural infection. That means 75 crore cases had occurred. RT-PCR, they had got the virus, means they were in this pandemic. First time in history, we were defining a case. Anyone with a virus or RT-PCR positive is defined a case. By that definition, we had 75 crore cases on June 2021. 75 crore cases as shown by the, and it is actually conservative estimate because after some time the antibodies level come down, but still the person is infected. I mean, person has immunity, person has past infection. Because the antibody levels come down after some time, it may not be detected in sero survey. At least 68% the detectable antibody levels. That means 75 crore people we should have detected by test, trace, and isolate technique, by test and tracing. And at that point of time, on June 2021, how many cases were on the worldometer? 3 crore cases were detected in India. By intensive test, trace, and all that, we could detect 3 crore. How much actual infections had taken place? 75 crores on a conservative estimate. So out of 75 crores, you could detect only 3 crores. That means you are detecting only 4 5% of the cases, and you are missing 95% of the cases. So it is, that's what I'm saying. It is not efficient. With all the effort and with all the panic, you are creating the panic. So you try initially in a communicable disease at early stage, very early stage. If you cannot, you let go. You try to conserve your resources and identify the high risk group. In this case, the high risk group were the elderly. You could have just protected them and only test at the most, only test the symptomatic cases. Don't keep on testing all the contacts, and after testing they are getting panicky and they are rushing to hospital. There was a medical stampede. That's what happened in the second wave. There was a medical stampede. Everyone with RT-PCR positive, they were booking their beds in the hospital in advance. They were booking the oxygen cylinders. Genuine patients may not have got the oxygen, and probably we could have prevented some deaths. So we should not create a medical stampede if you are following the epidemiological principles. So these figures are very illustrative. So novel coronavirus, as I said, the novel coronavirus is the dawn of all viruses. There is a, in the movie they say, no, dawn ko pakadna mushkil ही नहीं है, नामुमकिन है. So particularly in a country like ours, you are driving a car trying to chase the dawn. The dawn will hide in any house, overcrowded conditions, spread very fast, and you will not be able to catch the dawn. And there is a lot of collateral damage. And like all dawns, the fear factor is more than the actual lethality of the dawn. So, according to a paper, and it was established by a scientific paper in a July issue of 2021, over more than 5 lakh patients were analyzed, hospitalized patients were, data was analyzed, and this is the paper I have given the reference, and they found that the risk factor for severe disease, hospitalization, and death, the biggest risk factor was obesity, followed by the anxiety and panic. People who have anxiety, fear related disorders, that they had the highest level of severe disease and outcome. So, unnecessary creating panic by test, trace, when it is of no impact, as we have established by the figures. So, besides the phase of outbreak, context is also important. That first, as I said, the test trace is in the initial phase, like when you are driving, starting a car first, then subsequently the context, where, what is the traffic, like you adjust your car driving according to the traffic, according to the uh, GPS and other things nowadays. Testing and tracing important early, and when it is a localized stream, and once it has merged into the ocean, and we are a huge ocean of people, and end of the pandemic and testing tracing has got no. Again, when you are ending your journey in a car, when you want to slow down, you again come down to first gear. So at the end of the, not exactly pandemic, no, pandemic is ended, but coronavirus is alive. Long live the king, or long live the corona. Corona is dead, but long live the corona. Um, it has become mild. It has become, it is not creating so much morbidity or mortality. So now the question comes ki whether shall we want to eradicate it? Had it been a very severe disease like, say, we eradicated smallpox, we had to again, initially smallpox was there. There was, nobody knew when the journey started. So there was, but at the end of the journey of smallpox, I am talking of all viral diseases like small severity. The context is important. The mortality from smallpox was 30%, 40% mortality. Whole civilizations finished due to smallpox epidemics. So 30-40% it is worth eradicating. And COVID, the infection fatality rate up to 69 years of age is 0.05%. 0.05, matlab in 2000 people, one person may die, and that to a person who is comorbid, who is elderly. So, is it worth chasing this and trying to eradicate? And as it is, you have to go again to the first gear, and like smallpox was worth it because smallpox could be eradicated. It was feasible because there were no subclinical infections, and the any lay person could diagnose smallpox. No RT-PCR was required. It was evident, and the person would self, and by isolation and ring vaccination we could eradicate smallpox. Then you have to go house to house for the last case, very resource intensive, but it was worth it, and we could successfully eradicate smallpox. So again, at the end of means when you are trying to eradicate, the journey is over, you don't want to. But here the journey is continuing at a slow pace. You can just see the sightseeing, don't no need to end it, because it will be very resource intensive. Initially, you tried, it was highly inflated, infection fatality was highly inflated. There were certain distorted models by Imperial College, by Neil Ferguson, because they took the inputs from the nursing homes, where the average age of death was 80 years, and that was extrapolated to the whole world population. And India has a young population. Hardly 3% of the people are above 69 years of age in India, 3 to 4%. So 95-97% are experiencing an infection fatality rate of 0.05%, 1 in 2000, and children have got still lower. Below 18 years, the infection fatality is 0.0001, almost negligible. So these are the epidemiological principles, that who are affected, how much, quantify it, age group, age stratify, comorbidity, obesity, these are the risk factors. So accordingly, according to the epidemiological principles, you reduce the risk factors, in the long run, control obesity, control the comorbidities, and in the short run, protect those peoples. So this is the lesson which I want to say. You have to see the context, and all other endemic communicable disease have far higher infection fatality rate in our country. All other have got far higher infection fatality rate. And we are not counting like we are counting COVID. We are not counting or dengue. We are not counting or chikungunya. We are not counting or every 24 hours we were counting. Yeah, they were counting deaths. Here we are not doing that. We are not counting or typhoid. Typhoid has a infection fatality rate of 3% even after treatment, even because of drug resistance. Here it is 0.05 up to 69 year of age, and up to 70 depends on the comorbidity, because as you age you have got number of comorbidities, and in this we were, any death by any means, if a RT-PCR positive, the person may have died of some other primary disease, it was labeled as a COVID death. So this type of thing we have never followed. So this cause of death is also epidemiological principle. The cause of death has been sort of changed, I would say, in this year. So we have to classify the deaths according to the what led to the initiation of events leading to death. COVID might have been just an incidental thing. So that should not come in cause of death, but it came in this pandemic. So we have to, the epidemiological principles also says that your counting should be correct, your diagnosis should be correct, your death certification is also an important epidemiological tool. That epidemiological principles start with your cause of death. So in this there was lot of leniency in favor of COVID. So this is other endemic. We have to see the context. Like you have many other diseases. We are not interested. A person who dies, it is of no interest to him whether he dies of virus A or virus B or virus C or some other bacteria or some or traffic accident. Death is death by whichever means. So we have to see as a epidemiological principles. You have to each country will have, or each region or each community will have its own community diagnosis, and that community diagnosis depends on the disease pattern. In that each country has a different disease pattern competing, because anything, if you go only after one disease, and other diseases which are of more serious import, they get neglected. So these are or other. Chasing an elusive virus is futile and costly, and as I said, it has an opportunity cost. Resources are diverted from other public health problems. Like tuberculosis is a major public health problem, and during the COVID, even as per the WHO statement, India, the 40% reduction in case detection of tuberculosis, with the resources were diverted for COVID. Then unmeasurable cost, fear, stigma, and harassment. These are costs. If you are going for testing and all that, and person gets RT-PCR, if you remember in the early part of the pandemic, there have been cases a person got RT-PCR positive and he jumped from the building and committed suicide. I mean, this was a sort of uh, cost, fear, which cannot be measured. Losses due to restriction of trade and travel. There's so much collateral harm to trade and travel, and unnecessarily without following any epidemiological principles. You see, in our country, most of the people work in the unorganized sector. Unorganized sector, they are working in the open. They are the vendors. They are working in the footpaths. They are working in open, where the transmission is minimum. When you did lockdown, they went into the slums, and the transmission is intense in slums. So it is against common sense also. It is not a Western country that they have got huge houses and all that. Even middle class houses are crowded in our country. So, and on the yeah, you have suspended the trade also. During the lockdown, they lost their livelihood, and they did not get protection from infection. It did not matter that infection was of little impact on people who are young and healthy. Most are like Dharavi slums and other people. And then with this coronavirus has got so many families. So even the latest novel coronavirus, they say in Africa hardly had any COVID incidence and mortality, and they had minimum less than 5% vaccination coverage, and they did not have peaks, because they say the crowded countries of Africa and Asia, they have got either firstly they are not very obese, they are lean because obesity was a risk factor. Then other factor they say is they were younger, okay, and then they say ki they are living in crowded conditions. They are already exposed to number of coronaviruses. There are four families, and some cross protection may be there. May not be complete, but it may make the disease milder in them. And even if you see in Africa, there are two countries like South Africa has got a higher obesity. Egypt has got a higher obesity. In these two countries in Africa, they have got higher mortality from COVID. If you compare the data from the worldometer, we tabulated. And those countries which had lesser. Then another example is the Japan. Japan has got a very high elderly population. In fact, the longevity of Japan is perhaps higher than many European countries. So we expected that Japan will have high mortality. If you see the worldometer, they had the lowest mortality, one-third mortality compared to the Western countries. Why? Because their obesity rates, their overweight rates was one-third of the Western countries, one, 2.5 times less. The average BMI um, was higher. I mean, the overweight percentage. in Japan is around 25%, whereas it is 60% in the European countries. The European countries, Japan was age longevity was perhaps more than European countries, but their mortality was less, 10 times less compared to the Western countries. So it is not the age, more important was the obesity. Another example is the Brazil. Brazil has a younger population, but it has a obesity rate almost 60%, nearing the, and it had a very high mortality from COVID in spite of a comparatively younger population compared to the Western population. So this is a warning for developing economics like India. We are becoming more sedentary. We have gradually become obese, the middle class. So this is a window of opportunity where we should. This is also an epidemiological principle, because the highest risk factor in this pandemic was the obesity, even higher risk than even age, if you see Japan and Brazil. So this is the window epidemiological principle that inter-epidemic period you should minimize the risk factors. You should take care of the risk factors. One is the obesity, which we are gradually going into that because of our affluence, like Brazil. So this is also an epidemiological input I wanted to emphasize. And of course, the medical care of comorbidities like hypertension was a high risk factor, diabetes was a high risk factor, and they all go with obesity. If you reduce your weight, your BP comes down a bit, your blood sugar, insulin resistance comes down a bit. Yeah, and if you do physical activity. So these should be promoted. These are all epidemiological insights. And in the USA also they found, and Europe also, the marginalized people, the colored people, the blacks, and they had a higher mortality from COVID. And then they did some studies. They found most of them had uncontrolled hypertension, uncontrolled diabetes, because the access to treatment is not as good as the uh, Caucasians. So these are some of the, and the cost of contact tracing. As I said, chasing an elusive virus, cost of contact tracing in USA was $3.6 billion. I have given the reference. So you see, and India is 3 times more population than USA. So the futile test trace in USA, the cost was $3.6 billion. Of course, in India, the cost may be less because our things are cheaper here. Workforce is cheaper, local material may be cheaper, but still, you can see this cost of such a huge sum in testing, tracing. We do not have the figures which we should have. How much was spent on this testing and all that. And of course, there are people with conflict of interest, the kit manufacturers and other things. So many things come in the picture. Now, as I said, each country has its own public health problems, and epidemiology has to do the community diagnosis. Like you do a community diagnosis for an individual patient, you have to do a community diagnosis for a population, for a country, for a region. And in a large country like India, each region may have its own unique problem. So some of the problems for which data is available, as I said, unfortunately, many of the figures we don't have. So tuberculosis kills 1,400 young Indians daily. Young people, imagine. Here, COVID was killing people elderly. Or, I mean, any death is a tragedy, I agree. But there is something called disability adjusted life years. So, quality life is lost if a young person dies. Tuberculosis kills 1,400, and few months back, there was a shortage of anti-TB drugs in government supply. So, aren't we neglecting our own problems? For 3, 4 months, there were no drugs were available. Aren't we giving rise to extremely resistant tuberculosis, drug resistance tuberculosis? So these are our priorities. Then 4,000 children die from preventable disease against a background of malnutrition, diarrhea, respiratory infections, and 30% children in below 5 are malnourished. So isn't it again a young life lost with many potential life years? Road traffic accident kills over 400 Indians daily. Young people, again, road traffic accidents, you open the paper and these are the data from the police department. More than 400 Indians die daily. 400 Indians die. You see, people are going without helmet, without seat belt. They are jumping the traffic rules. And during the COVID, people are wearing masks, but they are not wearing helmet. They are not following the traffic rules. So you see how this the how the hype affects your psyche. Actual figure says ki it is more dangerous when a young youth takes a two-wheeler and rides recklessly. Parents are not worried, but parents were worried that close the schools. They put the mask, which had no effect also. Masks do not prevent transmission of virus. Even in fact, N95 only can check up to zero point 0.3 micron, and the size of the virus is zero point 0.1 micron. So even the N95 actually doesn't prevent. But this is what the epidemiological principles were just thrown out of the window. Rabies kills 18,000 to 20,000 Indians every year. This is number 10 is a WHO figure. Rabies 100% mortality. 18,000 to 20,000 Indians die of rabies every year. Very painful death and 100% mortality. And we are worried about disease X, disease say Nipah virus or some bird flu. Okay, those are dangerous things. But here in the present day, we are losing 18,000, 20,000 Indians from rabies. And Nipah virus, since 20, 30 years, till it was discovered, not even 1,000 people have died in 30 years all over the world. Not even 1,000 have died from Nipah, 1, 2. And here 20,000 Indians are dying every day. And just now I was reading a manuscript. As an editor, I get a lot of some information I keep getting. 50,000 deaths due to snake bite in India. 50,000 deaths due to snake bite in 20,000 from rabies. And we are worried of imaginary pandemics. Shouldn't we tackle this? This is what epidemiology is asking us. Then incomplete surveillance and monitoring of typhoid. As I said, whatever data is available, the mortality of treated cases also 3%, which is pretty high compared to 0.05% of COVID. Then dengue, Zika, chikungunya, malaria, JE. I had dengue last year, and I think this year only I had dengue 6 months back. Severe dengue epidemic is going on, was going on in Pune, Delhi. Pune was very worst affected. Dengue, I think I got all chikungunya because my joints kept stiff for almost 6 months. So I wanted to check the ministry site, ki what are the figures for dengue. And they did a RT-PCR, they could not find neither all, but all symptoms were severe dengue or chikungunya. And the data on dengue was not updated for the past 6 months. And my maid servant's daughter died of dengue, young girl, 16, 17 years old, because everybody doesn't have access to health services. That is another thing. The access to health services is not equitable. Again, epidemiology wants to have a equitable distribution. We do not have doctors in the primary health center, where the Bhore committee at the time of independence said that there should be a 75 bedded hospital with a medical specialist, surgical specialist, gynecologist. We don't have. We just have maybe one medical officer. Most of the time, even that is not available. District at the taluka level, block level, the Board committee recommended 650 bedded hospital with all the specialists. It's not, all the facilities are concentrated in the urban area. So, in such a large country, if there is a pandemic in future, people have to travel all the way from a remote area to the urban area, and they will be spreading the infection all through. So the field placement is not there. So these are a lot of things we have to do. We are just waiting for the next pandemic, and the panic level is risen, and the funds are diverted preparing the beds for, say, monkeypox have been prepared, extra beds. Then we are preparing beds for, say, Nipah virus or swine flu. And here people are not having access equitably. So these are some of the epidemiological principles which are actually not followed. The way forward, epidemiological principles demand that prevention and control priorities should be based on community diagnosis, that is public health burden. And I have given some of the burden in one slide. There are many burdens. This will be unique for each country and each region within a country. Even in a country like here, the regional variations are there, different geography, different climate, different year. It will depend on many factors: socioeconomic status, demographics, age profile is different, population density, and so on. Therefore, I have to ask the question to the listeners: ki, does one world, one health, this is the slogan nowadays, fit in this context? Can there be one world, one health when there are so many diversity? Can you have a car with one gear going at the same speed in a crowded Chandni Chowk and in a highway? You have to adjust the driving according to the roads and the traffic. So, how for disease you can have one world, one health? That is a question I am not giving. I have just shown the data. I have shown the principles. It is for the listener to think on it. And what about the proposed rigid WHO pandemic treaty accord and amendments to the international health regulations? That is the what is the proposal? There have been a lot of debate on this going on. It will be WHO will, if there's a pandemic, WHO will give the guideline, WHO will trade restriction, this, that, and the country will have no say. और मेरे घर में क्या हो रहा है मेरे को मालूम होगा कि WHO को मालूम होगा. So these are again no views from my side. It is for the reader to ponder. These are some of the references, all the facts, figures, all the statements I have made. You can freeze this site and check on the references, because nowadays everything has to be fact checked. Otherwise, you are accused of misinformation. So I have given the references, and I think that's all. Thank you, and stop sharing.
Thank you, Dr. Banerjee, for the presentation. Excellent presentation with a lot to learn. So we have a few questions from the audience. Let's go on to the first question. So my first question to you is, how important is data collection for accurate reporting and taking important measures? What should be done to get better data from nursing homes and hospitals?
Very right. Nursing home hospitals, okay. That is, as you said, you mentioned nursing home hospitals mostly, and they are, as I said, concentrated in the rural areas. So we have to do a homework first. We should have a health centers right from the sub center. Nursing home and hospitals are too much. Uh, it is not the periphery. You have to get the early warning system from the primary sub center to primary health center. And if you are not having equitable distribution, there are certain good reporting catchment centers where you can have the data trends, that is from the same center throughout. You can collect the data, that is known as sentinel surveillance, that you identify certain sentinels, like you have chowkidars who will give a early warning. So sentinel surveillance is like that. This surveillance center should be equitably distributed in the country to represent all areas. So you can get a. So for that, the groundwork has to be done. I mean, it is something like asking, ki, I want to start a new train. You have to first lay the tracks. Then only the new train will run. So if you have to have a good surveillance system, here the tracks are the health centers which are manned by people who can diagnose early and who can notify. And right from the sub center, it may be ASA worker also, to the primary health center, to the community health center, to the district hospital. So it has to be well spread out. Otherwise, you will get the information very late when patients from the periphery will start coming to the hospital and crowding it, and then spreading the infection all over the country. So it should be as near as possible to the patient. It is to the benefit to the patient also and benefit to the public health also, where you get an early warning system without spreading the infection far and wide.
Thank you for that answer. Moving on to the next question now. So my next question to you is, what are the current challenges in vaccine coverage and acceptance, and how can healthcare professionals play a more proactive role in addressing vaccine hesitancy?
Look here, this vaccine problem is like you are waiting for a new disease, and vaccine hesitancy is something which is unnecessarily stigmatized. Vaccine hesitancy arises when there is no transparency, when there is no data sharing, when there is no uh, communication to the people of the risk benefit. That gives rise to vaccine hesitancy. And vaccine hesitancy depends, all diseases may be prevented or may not be prevented by vaccine. If you are, if the disease, again, it comes to the community diagnosis. What is the public health problem? What are the alternative means? Like here, there we are having a lot of undernutrition. Children are dying of malnutrition, and they are very susceptible to measles. So, measles vaccine is one thing which I can communicate with good data that in a malnourished child, measles is 400 times more fatal than in a nourished child, well-nourished child. Again, the long-term solution would be to attend to the root cause. You eliminate malnutrition, even a well-fed child, well-nourished child get measles, the mortality chance is much less than a. So there is no across the board key. You have to remove vaccine hesitancy. You just can't wish away vaccine hesitancy by giving, it's not something like faith. You have to give the risk benefit. You have to communicate with the parent. This is the risk of your child. And firstly, if a malnourished child comes, your public health has failed. And these are the risks and these are the benefit. And you have to be very, very honest. So here, the vaccine hesitancy arose after this pandemic when nobody knew about it, but more were talking on faith rather than science. Because the vaccine developed very fast, nobody knew, but everybody promised much. People, to the extent responsible people said it is 110% safe, responsible people said it is 90% effective, and we now know that the vaccine efficacy doesn't last more than 3 months. So it depends. Like you should have first very robust data, and it from disease to disease you have to communicate. You cannot have a blanket key. You don't have vaccine hesitancy. Why? If a new vaccine is there, it is just like telling a pedestrian here why you see on the left and right. You just cross the road. That means pedestrian hesitancy. I mean, we are taught that when you are trying to go to a new place, you see left, right, then only. Similarly, if there a new product has come, the patient has every right for vaccine. In fact, I challenged one vaccine, this WHO consultant. He was on a panel with me. I said, "This your term, WHO term is not it's stigmatizing, as if vaccine hesitancy is something very much to be ridiculed. You cannot. Hesitancy has to be there. A scientist is always hesitant. Scientist in a new product, even the scientist should be hesitant. Hesitant does not mean that he is refusing the vaccine. He or she wants information, which is a hesitancy. Science is always uncertain. When the science moves towards certainty, it is moving towards faith and away from science. So hesitancy, even now, after so many years, for every drug, I have a hesitancy. For everything, I have hesitancy. But it can be communicated. And if I am convinced, I wouldn't say hesitancy will go away. I will take my own call. So that is the answer. I am very much allergic to this word hesitancy. If you are hesitant, doesn't mean you are anti-vaxxer. Certainly, I am certainly not anti-vaxxer. I have seen people die of diseases which are could have been prevented by vaccines. That haunts me. And I have seen people who have died from side effects of vaccine. That also haunts me. So there are no easy answers. That makes me hesitant at times. So there are no easy answers. So vaccine hesitancy, I would request the WHO to remove this term from their vocabulary.
Thank you for that answer. Moving on to the next question. So my next question to you is, could you share your insights on balancing individual rights with public health responsibilities, especially during a pandemic?
Yeah, that is a very good question because these are the public health bioethics. You see, this is an important topic. You see, there is a conflict between two principles of bioethics. One is autonomy, that I am free to do what I like, and other is the harm to others. That is the non-maleficence. So I am that. Then there is to reconcile that. Suppose I am a smoker. I like to smoke. I have got autonomy. But if I am smoking and now after the mm, people became aware that non-smokers also who are exposed to the smoke from a smoker are also at risk of certain diseases. So if I am smoking and if I am smoking in a public place, my smoking is also risk to the non-smokers. So in such situations, that autonomy can be curbed. And you are well aware now, many of the places are no smoking zones. Even five-star hotels are no smoking zones. Even aeroplanes, the smoke detectors are there in the toilets also. All public places have become a non-smoking zones. Airports are non-smoking zones. Nowadays, there is a separate place for smokers that only smokers smoke. So this is a situation like that. Similarly, in a communicable disease, a person is has to be quarantined. Like a person is coming from a like in yellow fever, you have got coming from an endemic area. That person is not having yellow fever vaccine. So he's coming from Africa, which is endemic for yellow fever. According to the travel regulations, if he comes to a country and if he doesn't have a valid yellow fever vaccination certificate, that person is restricted, quarantined for the day, 10 days, I think, incubation period. He loses his right of movement, but that is to save the larger public from getting yellow fever in case he is infected. So these are again you have to see the individual rights should not pose risk to others. Once it poses to risk to others, that can be curbed. This is the I think called the Miller principle. That is the way, and it can become sometimes difficult. Like suppose there is a confidentiality. If a husband is HIV positive, should the doctor tell the wife or not because of breaching? So again, there are certain dilemmas which are gray areas.
Thank you for that answer. And with that, we have reached the end of this webinar. Thank you so much, Dr. Amitabh Banerjee, for such an insightful and thought-provoking session. Your expertise has truly enriched our understanding of the vital role epidemiology plays in disease prevention and pandemic management. To our esteemed audience, thank you for your active participation and engaging questions. The knowledge shared today will undoubtedly help us refine our approaches in clinical practice and public health interventions. As we conclude, I would like to remind everyone that this webinar is a part of Docplexus 11th year anniversary celebration. We have more exciting sessions coming up, so stay tuned for updates. Once again, thank you, Dr. Banerjee, for your
Thank
invaluable
you,
time,
Sitil.
and
Thank you.
thank
It's
you
a
for all
pleasure.
joining us
Thank
today.
Doc Plexus for this opportunity.
Thank you so much.